Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Robin Roberts. She's Director of Health IT Regulatory Affairs at PointClickCare. Welcome, Robin.
Thanks, John. Thanks for having me.
Yeah, good to have you here. Longtime friend of Healthcare IT Today. And excited, first time on the program though, so this is great. For those that don't know you though, tell us a little bit about yourself and PointClickCare.
Definitely not a rookie in healthcare, but in the space for almost 2 decades. But here at PointClickCare, I primarily came on board a couple years ago to spearhead their certification of their health IT, and now overseeing where all of that regulatory policy meets practice for things like our AI solutions, all things TEFCA and interoperability, and of course, still overseeing some of our certified products and also helping our value-based care teams understand how that regulation meets practical realities for all of the customers we serve. Point Click Care, as I think a lot of your listeners know, is a healthcare technology company. And I think while we are most notably known as being a skilled nursing facility or SNF EHR, we also serve an acute market. We serve senior living, and we also have payers solutions as well, and hospital customers and ACO logos. And so, dealing with a lot of those segments across the ecosystem here at Point Click Care.
Yeah, it's been amazing to watch PointClickCare grow and also the regulatory environment. This takes me back to the early meaningful use Smith's days when we met, actually,
Yeah.
where it's like regulation was so important. I think that's kind of evolved today too. Today we're going to talk about the team, mandate regulations, et cetera. But those are taking effect in January. Team is mandated to, in January. Give us a quick rundown of what it is and what it's meant to accomplish.
Yeah, absolutely. The transforming episode accountability model is a mandatory value based care model that's going to kick off this coming year. And this is where a select number of acute care hospitals are being asked to focus on some very specific surgical episodes. So, everything from lower extremity joint replacement, surgical femur hip fracture repair, spinal fusion, cabbage, and major bowel procedures. And in this model, the goal is to improve care coordination for these episodes of care, reduce fragmentation, and really align incentives. But, John, as you know, it's holding the hospitals financially accountable for the cost and quality of care during these specific episodes. And this mandatory model is impacting what are designated core based statistical areas across the nation. And it is going to impact approximately, I believe it's just shy of 750 hospitals now. And so
Wow.
these hospitals are on the hook to manage those episodes for these selected surgeries, and they will be rewarded or penalized based on their outcome, the actual spend versus the target, not just for the surgery, but even for the care that ensues right after it.
Yeah. I mean, it's this whole shift to value-based care that you kind of mentioned. And, it seems like we're taking it piecemeal, like little by little. This is
Yeah.
another example of that happening. What would you say is maybe the biggest hurdle that hospitals face with this new mandate? And how can technology help them kind of get ahead of the mandate that starts in January?
Yeah, I think the biggest hurdle is managing the entire episode, even across the acute and post acute settings that's going to happen for these folks, right? Because it's not just measured upon what's going on in the hospital's proverbial four walls, but it's looking at everything that happens after the surgery happens. And I think hospitals arguably have continued to struggle with fragmented data and real time visibility once that patient goes home, once they go to a post acute facility or back to a skilled nursing facility. And so I think technology here has a place where we can integrate that data across the providers, use AI for things like early detection of things going on, facilitate that communication, and really give it a line of visibility and support for smarter discharge planning and post acute transitions. And hopefully, that's all going to help avoid costly readmission so that these hospitals ideally are having a more linear care pathway with as many of these patients as possible because we need to find a way to manage what's being measured.
Yeah. I mean, it's interesting because teams really calls for a lot of different things. Stronger coordination, smarter discharge planning, real-time data, right? Like it's a variety of things. If hospitals could only focus on like one of these things, right, as they start and they get ready, like which move gives them the biggest payoff?
Well, I'm glad you said that. And first things first, in year number one, it's upside risk only. They're kind of
Mm,
crawl, walk, run intro into the model. So if we have to look at what we're going to prioritize for the biggest payoff, the smarter discharge planning, I think, is going to offer the biggest payoff and that coordination because we do not want that avoidable readmission going on to we want to make sure that those patients are ensuring timely post-acute care. And so I think the effective discharge planning facilitated by some real-time data on where that person's going, making sure that that's a strong network partner in this model, and making sure you have a shared interest in an avoidable readmission is where the biggest win is going to come from. And right now, we know hospitals have been given those target prices based on predicate data. And so the time to be examining those things and planning for this first year to find where they need to focus, that time is now.
yeah. I mean, it's always interesting for me that hospitals and post-acute providers have worked in such silos, right? I mean, the fax machine is the biggest, connection between the two, which is unfortunate, with some notable exceptions, right? We've some have been worked together very well, but where do you see kind of the biggest opportunity for hospitals and post-acute providers to maybe partner differently under teams in order to see these savings and the upside risk benefit?
Well, the model tells hospitals that they can work with other stakeholders or these collaborators in the team. And so, no pun intended, you need a strong team. You
Mm,
need a preferred network. This is not unlike playing dodgeball in primary school, John, right? We want a preferred network of skilled nursing facilities and post acute providers that not only ease the transition, but are aligned on the quality metrics and in goals. So, ideally, if I'm a hospital in year one, if I want to alley oop my performance, I want a SNF partner or a post acute partner in and around my community that understands the need to carefully monitor these patients based on their care pathway, that they're elevating concerns, communicating in near real time, and I know what's going on. And so, if I can share my data with that person and have that reciprocity through technology or AI driven powered solutions to preemptively address those risks with strong, sustainable partners, that's who I'm collaborating with in the team model.
interesting. Yeah, I mean, it's never been a surprise, right? The hospitals that did have a preferred network of skilled nursing partners, that they would see smoother patient transitions, fewer readmissions. Like, everyone seemed to benefit from that relationship, right? And having those networks. But what would you say are the keys to building and sustaining those kind of collaborative relationships between, hospitals and post-acute care or SNFs?
I think if I could use technology to facilitate transparent communication channels or data sharing agreements, John, uh, that would be ideal. I want to make sure that I'm aligning my incentive. The team model even allows a hospital to share some of those shared savings pretty much as they see fit with those collaborators in the team model. And
Interesting.
so, but ultimately, we have to remember the hospital is on the hook for the outcome and where that price of that episode lands relative to their targets. If I'm the care management team or I'm post-surgical care and follow-up, I want to know, where are you in your post-acute stay? Have you spiked a temperature? Is there a risk of infection? I want the communication channel to know about that as prospectively or in near real time as possible. And so, and if I can align the incentives and consider sharing in the first year or subsequent years with the right partners to incentivize those behavior economics while having that transparent communication around that individual as it's happening while they're there 24/7 or at the bedside, that's where I think technology platforms can help the hospitals and the skilled nursing partners succeed together for these critical episodes.
Yeah, I mean, I think that's really interesting because technology can fix a workflow. You know what I mean? And fix in the sense not as correcting it, but as in codifying it for the culture of both organizations. That's a fascinating way to look at technology, because I've seen that happen a lot. But you're right. I mean, I think it is about the incentives, and we've seen this before many times over the years, that the hospital's benefiting, but the post-acute does the work. Like, how do you align those incentives and the work that needs to be done? That's really interesting. Post-acute care has sometimes been considered kind of this black hole, this data black hole. You send them off, you don't really know what happens, right, from an acute care perspective. And to be fair, the acute care has moved on to the next patient in many cases as well. So, how can AI and predictive analytics finally give hospitals kind of that foresight to be able to prevent readmissions before they happen? Because we all know every acute care wants fewer readmissions. They're getting paid based on that too. So.
Yeah, absolutely. When we talk about real-time data, it's not the hospital data, it's not the SNF data, it's about the individual patient.
Yeah.
I'll tell you that we see a lot of technology. I think you can agree as well. At nauseum, one of the things I'm really excited about that PCC has done is PRTH, predictive return to hospital. They have leveraged some source attributes in the patient's data for any patient, but in particular, you can focus on these teams' patients, these specific surgical episodes that are so imperative to outcomes and shared savings, or the incentives that can happen relative to target pricing for those hospitals. And what it's doing, John, is we are quantifying a categorical risk of somebody's propensity to return to the hospital, right? There's a cut line, and in the post acute world, in the SNF world, it is 24/7, 365. It does not stop. We got to have to know who to prioritize, why, and how. The predictive return to hospital model is helping enable that proactive, timely intervention for the right person to possibly mitigate hospitalization or have clarity around why that individual might be at risk to return. And so that can be integrated with the hospital's EHR. They can have those same shared insights for the post acute encounters going on. And so that's the kind of place where I think AI and predictive analytics have a place to help us surface and highlight the patients that need that attention.
Yeah. Well, we have so much data coming at us. We need that to be able to sift through all the data to know what's important. Who would you say should lead this, or, the team effort? Is it the, acute care hospital side? Is it the post-acute care? Obviously, it takes the collaboration. If everyone's not involved, you're not going to be a success. But who do you see leading? Do you see both sides, or how, I'd love to hear what you're seeing in that regard.
I see both sides leading it, John, right? Ideally, the behavior economics here have to get in line aligned, which is where I think the team model and the regulation does a good job saying I can share some of that benefit potentially with the right partner if I would choose to do so. And so ultimately, I think the hospital is the key driver. As we said, they are accountable for that outcome, for meeting or beating those target prices for these surgical episodes. And so I see them being the driver. And I think that they need to have immaculate communication, that shared data and transparency, and the right system and tooling to make sure that the post acute side of things is aligned, right? It's not about them staying for the longest possible time frame. It's not about us overdoing anything. It's, having appropriate level of service, managing risk, managing potential risk for readmission. And so I think the hospital is the key driver, but there also has to be alignment in that preferred network of those SNF partners for these
Yeah.
particular cohorts of patients under the model, because this model is mandatory. It is running until the end of 2030. And I think we're just going to continue to see more iterations of models like this one coming out of CMS a lot faster, especially in the few years to come.
That's a great point. This is just the start, right? Like, so
Great.
you might as well figure it out now so you're ready for whatever comes in the future. Well,
Absolutely.
Robin, I appreciate you taking time to talk with us and share your insights and perspectives. Team is right around the corner, so hopefully everyone listening can dive into it and create those collaborative partnerships that benefit their organization, but also benefit the patient. It's always important to remember that. Everyone can benefit at the same time. So I love models like that. And thanks so much for sharing your insights and perspectives. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, Robin.
Thanks, John.